Thank you for that wonderful presentation. Next, we'll please welcome Dr. Biniam Kidene, a researcher from the University of Manitoba in Winnipeg, to speak with us about life after KLGB 140503 and deciding extent of pulmonary resection for stage 1 non-small cell lung cancer.
Thank you very much. Is this actually audible? Is this better? I feel like I need the bigger thing. It's very difficult to follow Dr. Tsuboy. It's a real pleasure to be here. These are my disclosures, none relevant to this talk. Can you guys still hear me, or do I need that microphone? Is that okay? Good, perfect. So we're going to be talking about this trial, otherwise known as the Altorki trial because of the first author. This is a non-inferiority randomized phase 3 trial, and at the risk of perpetuating stereotypes about surgeons being knuckle-dragging troglodytes, the bottom line is, it doesn't matter. And with no offense to segmentectomy, it doesn't matter if it's a wedge, it doesn't matter if it's a segment. This is the description of the study. As you can see here, they compared 357 patients to 340 patients with sublobar resection. The sublobar resections could be anatomical segmentectomy, as very nicely described by Dr. Tsuboy, or wedge resection. The very important thing to note about this trial is that 60% of the sublobar resections in this trial were wedges. So the vast majority of the effect that you see is actually driven by the wedge rather than the segmentectomy. And as you can see here, the primary outcome was disease-free survival at 5 years, and it was non-inferior. We have to always remember the eligibility criteria. These have to be peripheral, 2 centimeters or less lung nodules. The key difference in this trial versus the JCOG trial was there has to be a solid component with no GGOs allowed. The ECOG status ranged from 0 to 2, and it mandated intraoperative lymph node sampling. And for the right side, it would be 4, 7, and 10. Left side would be 5, 6, 7, and 10. And the exemption was that nodes that had been sampled within 6 weeks of the surgery by mediastinoscopy, EBUS, or EUS did not have to be resampled. So this is key when we think about how to transport this to the real world. I don't expect you to really read this. The basic idea with this is the Table 1 baseline characteristics. And the major difference is, I think Dr. Tsuboy might have mentioned this, is that there was a lot less never smokers in this trial and a lot lower proportion of adenocarcinomas in this trial. As Dr. Hanna mentioned yesterday, the 5-year disease-free survival is about 64% for both groups, which I think led him to surmise that there's something worse about thoracic surgeons in North America versus Japan. I think that, or I think what he was trying to get at was that we're much better at doing wedges, but less better or worse at doing segmentectomies. Dr. Hanna is a big proponent of segmentectomy, and I think he was trying to actually subtly bias people and not tell you the truth. In reality, it's a very different patient population, but the overall survival is about 80%, so it's quite good. Needs to be better, quite good. The point of this slide is just to show you that across all subgroups, the effect is consistent. So whether or not you're looking at age, sex, or tumor size, it's still non-inferior. The impact of local regional recurrence. So what is the pattern of failure? What is the pattern of recurrence? Majority tend to be distinct. There's a slight increase in local regional recurrence with sublobar resection of about 3% higher, but this is not statistically or clinically significant. And the bottom, I don't know if I can see this here, but the bottom pulmonary function outcome is just showing you that, as you can expect, you get a little more loss in pulmonary function with lobectomy than you get with sublobar resection. But the main thing to really think about is that the higher risk to your quantity of life, meaning that risk of death after a surgery, and the higher risk to your quality of life, how you feel after pulmonary surgery, is actually a lot more complicated than PFD loss. I'm not going to delve too much into it here, but the other hat I wear is as a physiology researcher in terms of the implications and inflammatory consequences of lung surgery and one lung ventilation during lung surgery. And the reality is actually what our conceptualization of what incurs risk in thoracic surgery and lung surgery is actually very different than what we think of it. It's not that people are getting a lot sicker because they miss that 10% of junk lung that they're losing with a tumor in it. It's actually the implication of the one lung ventilation in a person that's already has that kind of compromised lung function, and it has inflammatory consequences. So the reality is that people's sense of quality of life reductions are a lot more complicated than the amount that they lose in their PFTs. And unfortunately, we don't have quality of life data from this trial. So how do we conceptualize life as a surgeon after this trial? Well, I purposely put this slide up, which is an ad for the movie Wild Wild West with Will Smith in the 90s. And there's about 2 types of reactions to this trial. And I remember being at World Lung in Vienna when just before and after Al-Torki presented this trial with actually, I think, Drew and a few other radiation oncologists and thoracic surgeons. And there was a variety of reactions. So for some people, and I call these the segmentectomy champions, the other extreme word to say in some people is segmentectomy zealots. Forgive my utilization of that term. But it was a sense, much like this 1990s movie, that they had a great hope for this trial. They had a great anticipation that this trial would finally show what they always believed, which is that wedge resection was much worse than segmentectomy, thereby solidifying the dominance of segmentectomy over wedge resection. And much like what happened to most people after they watched this movie in the 1990s, they were met with very, very, very florid disappointment and disillusionment. So that was one proportion of people. There was a different proportion of people who had a different reaction to it, and I call it the pragmatists. And the pragmatists, I count myself as one of them. Obviously, I'm going to paint myself as the protagonist of my story. But we saw this as somewhat being quite consistent with what the signal had been a long time. That when you look at high quality wedge resections, when you're looking at the data in select populations, actually it didn't make the signal was consistent. Wedge resection actually could be a good operation as long as it was done in right hands. And for many of us in this camp, the belief that segmentectomy was always better than wedge resection in most trials, especially the kind of dirty trials, retrospective studies, NCDB studies, SEER studies, was actually because it probably was acting as a proxy for the quality and the training of the surgeon. That people who were doing segmentectomies were also more likely to do much more or better quality wedge resections. So this is always the confounding factor. For us, the Wild Wild West that we were worried about actually is different, which is that we were worried that people would start taking the wrong impression from this trial. That if you assume that most of the effect is driven by wedge resection, and if you assume that that wedge resection or sublobar resection is non-inferior, we can no longer discourage wedge resection. So this could lead to a lot of bad behaviors, a lot of rise of indiscriminate wedgers. And I want to take just a second to talk about this trial, or this study. It was actually an NCDB study by Seth Krantz. And this looked at a whole bunch of wedge resections and SBRT-treated lung cancers. And what they showed is that when you have high-quality wedge resection, so this means good margin, R0 resection, good lymph node sampling, that it almost acted like segmentectomy, that it was high-quality, good survival. But when you have a poor quality wedge resection, it was quite poor. And the poorer the quality, the less R0, the less node sampled, they decrease the survival. And in this study, they said that a poor quality wedge is no better than SBRT. I'm not trying to be inflammatory here, Drew. And he's taking a picture for Twitter, I'm sure. But this is not meant to be derogatory towards our SBRT, but rather to show that there is a gradation of effect according to the quality of the wedge. So what do? We have to be careful because there have been a lot of advancements over the years to reduce this cowboy approach of just wedging it out. In the US, it was a big problem with any surgeon who can put up a shingle, just cutting out little samples from the lung and calling it a curative resection. This has been discouraged through system level and culture changes across the last decade. And we are afraid, many of us, that this could take us back, this kind of trial could take us back to the dark days. So how do you avoid that? And I think it is up to us now to make sure we have a campaign to clarify what a high quality wedge is, clarify how to do it, and to make sure we highlight that case selection is very important. And there's a lot of efforts undergoing right now, one of which is being led by this Thorn group, and of which that Seth Krantz, surgeon from Chicago, is one of the leaders. So to conclude, sublobar resection is good in select patients. Wedge is no longer a dirty word. We have to pay attention to selection and quality. And the reality is this is actually better for our patients, because if we harness this evidence correctly, we can offer treatment, curative treatment, to a wider and wider group of patients. I'm not going to get into this too much, lest I be accused of heresy, but there is implications for higher stage disease, and I think we kind of touched on that in the previous session. What are we trying to really do with resection, with surgical therapy? Of course, this applies to 2 centimeter node negative disease, but what does that mean about organ preserving therapy in the future when you combine systemic therapy, targeted therapy, and dealing with a local disease with a local treatment, rather than trying to do pneumonectomies for something that does not require that degree of local therapy? Thank you.